Today we are starting the series of lectures on nephrology, especially pathology of the renal system. And we will start our discussion with the pathologies related with the glomerular injuries, right? Especially our topic will be around glomerulopathies. Glomerulopathies and glomerulonephritis, right? Before I really go into detail of glomerulonephritis or glomerulopathy, I want to introduce the concept that once you injure the glomerulus, whatever the mechanism of injury, whenever you injure the glomerulus, right, what is the clinical problem starting there? Is that right? Let me draw the basic structure of glomerulus. You know glomeruli are filtration unit in the kidney. One kidney has how many glomeruli? Question goes to Muhammad. Oh, I think you have been counting that. Right. So he's right that one kidney has about 1.2 million nephrons, and together both kidneys may have 2 to 2.5 millions nephrons. So I'm not going to draw all of them. I will just draw one glomerulus, and the same principle will be applied to the rest of the glomeruli on the both kidney. Right. So let's suppose that this is glomerular capillary, right? Here the blood is coming from afferent arteriole. Here the blood is going out to efferent. Yes, please, efferent arteriole. And here is your glomerular basement, GBM, glomerular basement membrane. And here is your Bowman's capsule or urinary space, right? And here is connective tissue which is called mesengium. What is that? Mesengium. Is that right? Now, of course, you know capillary is lined by which cells? Endothelial cells. You have to be with me. And this side of the basement membrane is lined by special type of cells. What are these cells? These are podocytes or epithelial cells, right? These are visceral epithelial cells, and here in the Bowman space, these are parietal epithelial cells. And of course, now there is the beginning of proximal convoluted tubule and remaining nephron. Now, one thing which should be clear, that when we are talking about the glomerular diseases, we must be very, very clear about this filtration membrane, because glomerular diseases alter the characteristics of these filtration membranes. Normally, it has three components: endothelial cells, then there is glomerular basement membrane, and then there is epithelial cells, right? This endothelial cells, these are fenestrated cells. When we say endothelial cells are fenestrated cells, it means that there are fenestrations present within the endothelial cells. What are fenestrations? Fenestrations are the pores, right? These endothelial cells are porous. These endothelial cells are porous. They are having fenestrations, right? And one fenestration, for example, this is one fenestration, but there are thousands and thousands of fenestrations present in every endothelial cell. This fenestration, one fenestration has a size of about 70 to 100 nanometer. Is that right? So this is the fenestration size. Opposite to that, the size at this side, epithelial cells, there are filtration slit. You know, these 2 points between the epithelial cells, they are called filtration slits. Let me tell you how they are applied there. Can you give me your copy? Can you give me your copy? Right. Let's suppose this is glomerular basement membrane, right? And this is podocyte. I think it is congenitally defected. Now, this is podocyte. Podocyte is applied under it. Is that right? Now, in between the podocytes, other podocyte and this podocyte, they will interdigitate their foot processes, right? So what really happens that under the glomerular basement membrane, you have podocytes which are interdigitating like this, right? And with the fingertips, they are sticking with the glomerular basement membrane. Why I'm saying that with the fingertips, they are sticking with the glomerular basement membrane? Because in some glomerular diseases, right, these molecules which are holding the podocyte with the glomerular basement membrane, these molecules become defective and podocytes fall away, and of course that will be a tragedy. So what I'm saying, the podocytes are just applied on the glomerular basement membrane on the Bowman capsule side, and they are interdigitating process. And where are the filtration slits? Filtration slits are the gaps between the interdigitations. For example, in between my fingers, you find there are gaps. These gaps are called filtration slits. So we can say the substances are allowed to pass through fenestrations here, and eventually they have to pass through this filtration slits, and until podocytes are properly applied on the basement membrane, there will be physiological filtration. But if podocytes or their foot processes, which I call fingertips or foot processes, technically speaking, foot processes of these cells, if they detach, then it will become more permeable. Now, the size of the filtration slit is about 20 to 30 nanometer, and this was on endothelial cells, this was 70 to 100 nanometer. Now you know the barrier size here is size barrier 70 to 100, and here size barrier is 20. Is that clear? Now, another important point is that all the things which have to pass through that, they have to be small enough to pass through these barriers. Is that right? There is one more mechanism which also determines the barrier to the filtration. One barrier we have discussed, the size barrier. Size at this point and size at this point. So size of these pores act as a barrier for filtration. There is one more mechanism of barrier. That barrier is negative charges. There are negative charges on this endothelial cell, there are negative charges on the glomerular basement membrane, and there are negative charges on the epithelial cells. So we say there are many negatively charged molecules present on this filtration membrane at multiple levels. Now these negative charges repel the negative molecules, negatively charged molecules. You know, plasma proteins are normally at physiological pH, plasma proteins are charged negatively. So plasma proteins are repelled by these negative charges. So any molecule or plasma protein or RBCs, WBCs or platelets or any substance which has to go down, it has to face the size barrier as well as charge barrier. Am I clear? Let me talk about especially albumin. The molecular size of the albumin is just enough to pass through the size barrier. Molecular size of the albumin, which is about 70 kilodalton, the molecular weight of the albumin, that is just enough to allow the albumin molecule to pass through these barriers due to their size. But normally albumin does not leak out. Why? Because albumin is negatively charged and these membranes are also negatively charged. So albumin is repelled. Another explanation of this is there is a disease called minimal change glomerulopathy. In that disease, there is no big structural defect here. The real problem in that disease is that negative charges are neutralized. As soon as negative charges are neutralized, a lot of albumin start leaking down. Whole this concept is clear? No problem. After this barrier discussion, now we come to different patient with different degree of injury to glomeruli. Right? Now, if there is, let's suppose there is very mild injury to this person due to any mechanism. Let's suppose due to some immunological mechanism, which I will discuss into detail later, there is a very mild injury. Suppose we can say grade 1 injury. Grade 1 is not a medical term. I'm just for explanatory purpose I'm saying that let's suppose someone has in his glomerulus very, very minor injury. When there's a very minor injury, the smallest molecule will start leaking. Now the smallest molecules are albumins. So what really happens, here is your albumin, here is your globulin, here is your fibrinogen. Now what really happens, that as soon as there's little injury, albumin start coming down into urine. And we say that there is albumin, urea, right? And because only albumin is selected to be leaky and globulin is not allowed to leak, so we also call this situation either only albumin urea, or we say patient has selective proteinuria. Is that right? But next time you come across a term selective proteinuria, it means that albumin is allowed to leak, but the damage is not enough to allow the globulin to leak. Is that right? So selective proteinuria is also a term which is used over selective proteinuria, right? So with grade 1 injury, right, or plus 1 injury, okay, make it simple. With plus 1 injury, right, which is very, very mild injury, you have only albumin leaking down. Now, let's come across another patient in which injury to glomerular structure is more than the first case. And if injury to glomerular structure is more than the first person, let's suppose here is plus 2 injury. It means membrane will become more leaky. And this time, this patient will have not only albumin coming down, but this patient will also have globulin coming down. So albumin is there, plus globulin is there, right? And this type of proteinuria is called, yes please, it is called non-selective proteinuria, right? Let me repeat it. It is this plus 1 injury, only albumin is allowed to leak, but globulin will not leak. But injury is slightly more than that, then not only albumin will leak, but with the albumin, globulin will also leak. And we say there is non-selective proteinuria. And now we go to another person where injury is suppose plus 3, right? Now what will happen? In this person where injury is more and pores are increased in number and increase in size significantly, of course, this person will have albumin urea, but very heavy albumin, plus this person will have globulin urea, but far more than the second patient, because injury is more. So proteinuria in the third patient, right, is more than the second patient, and if albumin urea become more than 3.5, if proteinuria, of course it is selective proteinuria or non-selective proteinuria. This is non-selective proteinuria. If this proteinuria here is more than 3.5 grams per day, or it is more than 3.5 grams per 24 hour into urine, right, then further complications are starting, right? And this concept is very important, the difference between patient number 2 and 3. Patient number 2 has non-selective proteinuria. Patient number 3 has also non-selective proteinuria. But here proteinuria is less than 3.5 grams per 24 hour. But in patient number 3, proteinuria is more than 3.5 grams per day. And once proteinuria in urine in adult become more than 3.5 grams per day, there is a major change in the whole clinical picture. What is the change? Actually, normally what happens that when there is, let me make that this is your circulatory system, right? When there is proteinuria, proteins are being lost into urine, right? Then this is the duty of the liver to compensate the proteins. Major source of plasma protein is liver. Hepatocytes are the synthetic machines, right? So as proteinuria increases, normally liver increases its synthesis of proteins so that it can compensate and maintain the reasonable level of plasma proteins in the blood. Now, if proteinuria become more than 3.5 grams per day, then liver, in spite of its full compensatory effort, will not be able to maintain the plasma protein concentration at appropriate level. What is the normal per day production of proteins by the liver? Healthy liver can produce maximum how much proteins per day? Plasma proteins. Anyone? Attention please. Question is so simple that a normal healthy liver can produce, when it is working at the maximum to compensate the urinary losses per day, how much plasma protein it can really synthesize? 78 what? 78 grams per, oh, I think you have some monster's liver. Yes, yes. 3.5. He tried to be logical, because he think that if 3.5 is lost, or if loss is more than 3.5 grams, and then hypoalbuminemia develop, it means liver cannot compensate. So he logically thought out that it means liver cannot produce more than 3.5 grams per day. And there he is wrong. Medical science, like life, is not that simple. Liver can produce daily 10 to 12 grams per day proteins. Plasma proteins which can be produced by healthy liver, 10 to 12 grams per day. But whenever in the urine losses of more than 3.5 grams, blood proteins levels start going down in spite of the full production, and we say hypoproteinemia develops or hypoalbuminemia develops. What is this mystery? That only 3.5 is coming into urine and it is able to contribute up to 10 to 12 grams, but patients start developing hypoproteinemia. Who will solve this mystery for me? Isn't it mysterious? That from your pocket 3.5 is dollars going per day out, and you put $12 daily, but still your dollar level in the pocket is shrinking. What is happening to your pocket? Yes, you have some idea?
Maybe it's not only albumin it's making a lot of proteins.
No, I'm right now concentrating about the plasma protein, which are mainly albumin and globulin. And here the losses are albumin and globulin. Anyway, I appreciate the way you thought it. He thought that 10 to 12 grams mean it is making many proteins, and out of them few are albumin and globulin. This is not the right answer. The reason being 10 to 12 grams per day, I'm talking about plasma proteins, especially albumin and globulin. I'm not talking about other coagulation factors and other complement proteins and other proteins. Is that right? The problem mystery is that someone who starts losing more than 3.5 grams proteins per day into urine, plasma protein levels start going down in spite of compensatory synthesis of 10 to 12 grams per liver. If someone can answer, fine, otherwise I'm left with the answer.
Most of the rest of the proteins will be bound to all the molecules.
Okay, before you come up with the very new theory which no one knows, let me explain. Right? So, actually, the real loss from here is not 3.5 grams. Here are your friends, proximal convoluted tubular cells, and they love to eat up the proteins. The proteins which are leaking down, many of them by pinocytic process are taken up into these cells. Which cells? Cells of proximal convoluted tubule. And lot of proteins are catabolized there. So whenever extra proteins are lost from the blood to the Bowman space, right, only some proteins appear into urine and a lot is destroyed in the proximal convoluted tubule. And this is the loss you are not concentrating on. Proximal convoluted tubules are concerned with the catabolism of small molecular weight proteins. Is that right? So naturally, when there's no protein leakage, no significant losses here, no significant catabolism here. But as soon as there's a disease which damages the glomerular structure, a lot of proteins start leaking down. Maybe total protein is leaking 14 grams. Out of that 14 grams, maybe 5 grams come down here and 9 grams are destroyed here. Is that right? So basically, there are two types of losses of the proteins which are pathologically filtered from glomerular barrier into Bowman space. Some of the protein really appears into urine, and some of protein is catabolized in proximal convoluted tubule. Is that clear to everyone? Right? So what really happens once there is heavy proteinuria? Heavy proteinuria is a term to be used when protein losses in the urine are more than 3.5 grams. When you have a heavy proteinuria, then you start developing hypoalbuminemia. What you start developing? Hypoproteinemia. Of course, plasma proteins will be less, albumin will be less, and globulin will be less if it is non-selective protein losses. When plasma protein levels goes down, plasma proteins do a lot of function. One of the very important function is that plasma proteins maintain the osmotic pressure or oncotic pressure within the circulatory system. Plasma proteins maintain the osmotic pressure within the circulatory system, right? You know that hydrostatic pressure, for example, this is an artery, here is a capillary network, and here is the vein. Now what really happens? Hydrostatic pressure is pushing the fluid out into interstitial area. Hydrostatic pressure is pushing the fluid out. And osmotic pressure exerted by the plasma protein is pulling the fluid in. Is that right? So capillaries on their arterial end, capillaries when they are on the arterial end, hydrostatic pressure is more. Hydrostatic pressure is more than the osmotic pressure of proteins. So fluid leaks out. But as blood moves from arterial end of the capillary to the venous end of the capillaries, hydrostatic pressure drops. And within this part of the capillary, osmotic pressure is more than the hydrostatic pressure. So fluid which has gone to interstitial area, it is sucked back. So this is a normal mechanism that in every tissue, normally, constantly, from arterial side of the capillaries, fluid is leaking out, adding to interstitial fluid, and fluid on the venous end of the capillaries, fluid is constantly taken back to the circulatory system due to high osmotic pressure. Again, listen. Osmotic pressure of protein in most of the capillaries around 27 millimeter of mercury. But hydrostatic pressure here is 40 and here it is maybe 15. So along the capillary length, it is the hydrostatic pressure which mainly changes. In the beginning of the capillaries, hydrostatic pressure is more than osmotic pressures or oncotic pressure. At the end of the capillaries, hydrostatic pressure is less than the oncotic pressure of proteins. So what really happens? That all the capillaries on their arterial ends, they are allowing the fluid to go out, to take the oxygen, carbon dioxide, glucose, amino acids, and many things to the cells. And on the venous ends of the capillaries, right, fluid is coming back to circulatory system, right, to bringing the waste product. So what's really happening all over your body? That in every tissue, fluid is coming out of capillaries, washing the cells, giving service to the cells, providing the nutrients, removing the waste product, going back from the venous end of the capillaries. Am I clear? Now, in our patient, there is significant injury to the glomerular structures and there have been heavy proteinuria, and due to heavy proteinuria, patient develop hypoproteinemia, and when proteins level becomes significantly low, then osmotic pressure in the capillaries becomes so less that on the arterial end of the capillaries, extra fluid is leaking out, and on the venous end of the capillary, reclaiming of the fluid by the circulatory system is poor. So excessive fluid accumulate in interstitial spaces, and that adds to the situation which is called edema. And because this happens all over the body, we call it generalized edema. And severe generalized edema is called anasarca. Severe generalized edema is called anasarca. So you understand that after heavy proteinuria, you develop hypoproteinemia, especially hypolipidemia, and that clinically translates into what? Generalized edema. A special point. Edema of the renal system, especially edema which develop due to protein losing nephropathies, initially start around the eyes and then face. Then it spreads over all the body. So we say edema of renal origin usually start or initiate as periorbital edema. And later on it will become all over the body, and this edema will be more in the dependent part of the body. Why it starts, why it is more in the periorbital region? Raise your hand, who can tell me? Mechanism of edema, you know, that there is less osmotic pressure due to low plasma proteins, so fluid is excessively lost from vascular compartment to interstitial compartment, and edema is developing all over the body. Who will tell me why in periorbital area edema is more? Answer is very simple. Have you heard of this thing or never heard? You must have heard somewhere, or you will hear that renal edema. If someone patient come and he say daily in the morning when wake up there's too much swelling around the eyes and then on face, you must start suspecting, or you have to rule out the urinary losses of proteins. Okay, let me tell you. Actually, tissue here is very loose. Skin is very poorly attached with the underlying tissue. You know, you can take it up, right? But can you take skin from here up? You cannot. Here it is tightly held. So if capillaries are leaking here, can they build enough pressure to push it away? No. But here, because it's loosely attached, a little increased excessive fluid will swell up without building a pressure in the tissue. So more and more fluid will keep on accumulating. Could you understand it? That this connective tissue, it is where the skin, it is very loosely held with underlying tissue. So when capillaries leak here, fluid come out, but because this tissue will move forward, it will accommodate the extra fluid. It will accommodate extra edema fluid without raising the local pressure. So more fluid will come. So this area will become edematous earlier. This is one of the very important clinical points related with the edema of renal system. Is that right? Periorbital edema. Secondly, I told you this edema will be all over the body. And this edema will be pitting edema or non-pitting edema. You have a concept of pitting and non-pitting edema or no concept? Okay, let me tell you. I will just try to give you the concept of pitting and non-pitting. These three very simple diagrams. It's a side discussion from our lecture. But let's suppose this is capillary, this is arterial end, this is venous end. Again, this is capillary network, arterial end and venous end. These are three patients. Patient A, patient B, patient C. Now, normally what happens, you know it. Hydrostatic pressure is high, pushing the fluid out. And osmotic pressure is pulling the fluid back. And in this way, fluid is being added from the capillaries continuously to the interstitium and taken back. Is that right? In the first patient, patient A, there is increased hydrostatic pressure. Due to some reason, hydrostatic pressure becomes very, very high. If pressure in the capillaries become very high, then leakage of the fluid will be too much. Leakage of the fluid will be too much. Now fluid is extra filtered because of the high pressure, but endothelial cells have normal permeability. Only the pressure dynamics are changed. Is that right? Now, when fluid normally leak out, a little amount of protein also come here. But this little amount of protein cannot be pulled back. Normally, right now in your body, wherever the fluid is filtering out, with that fluid, a very little amount of plasma proteins also leak out into interstitial area. But this plasma protein cannot be sucked back by the capillary system. But nature does not allow these plasma protein to accumulate here progressively. These plasma protein are drained by the lymphatic system. And lymphatic in the end drain into veins. In this way, in spite of the fact the capillary do lose a small amount of proteins, these small amount of proteins do not accumulate into tissues. They are drained by lymphatic system. Am I clear to everyone? Now, we come to the first patient. High hydrostatic pressure, excessive fluid come here. Now, lymphatic system is working well. So fluid is coming here too much. But do you think proteins will accumulate with the fluid here? No. Is that clear? Now we come to the patient number 2. In this case, hydrostatic pressure is normal. Problem is with oncotic pressure. Plasma proteins are less and osmotic pressure is less. In this case, also the fluid will be filtered. Will be normal or more than normal? Fluid which is filtered is more than normal, right? But do you think excessive plasma proteins are filtered? They are normally filtered. But here lymphatics are also working. So, if lymphatics are functional in patient B also, even if small protein which is leaking, it will be drained. So it means edema formation is in patient A as well as in patient B. In patient A, edema formation is due to excessive hydrostatic pressures. In patient B, edema formation is due to reduced oncotic pressures. But in both cases, whatever small proteins are filtered, they are successfully drained by lymphatics. So mainly fluid accumulates. And this fluid, right, this will be, some of it will be drained by lymphatics, but usually there's so much fluid that it overwhelms the lymphatic drainage system. Now we come to the third patient. In the third patient, hydrostatic pressure is normal. Hydrostatic pressure is normal. Even oncotic pressures are normal. Do you think patient can develop the edema now? Can patient develop by some mechanism edema now? Yes. That is by blockage of lymphatics. Lymphatics eventually drain into venous system here. Now, if there is some disease which has blocked the lymphatic system, for example, some parasites, or lymphatics are blocked by the cancer cells, or lymphatics are blocked by the fibrotic process, inflammatory process, by any reason. If lymphatics of the system are not, tissue are not working, the small amount of proteins which leak out, they cannot be drained. Over the months and years, those very small amount of proteins keep on accumulating. And when these proteins will accumulate pathologically here, which were supposed to be drained by lymphatics, and these proteins will increase the osmotic pressure here and hold a lot of fluid. And whatever fluid is coming out, all of it is supposed to go back, but a small percentage of the fluid will be sticking to proteins, held by the proteins. So here edema will be formed. But this edema in patient C is different than the edema in patient A and B. What is the difference? The difference is that here edema fluid is held tightly with infiltrated proteins. Now, if you press this tissue with finger, here is only fluid. When you press with the finger, fluid is displaced. Edema fluid is displaced, right? So you will be producing a pit here. With the finger you can produce a pit here. So this is called pitting edema. This is called pitting edema. In the same way, in patient number B, again if with the finger you press that tissue against some bone, edematous tissue, with little 30-second pressure, what really happens? Fluid is displaced. And because fluid is not held here with anything, so it will be displacing from that pressure under the finger, and this will be also pitting edema. But if someone has edema due to lymphatic obstruction, fluid is held tightly with the deposited proteins. With the finger if you press, can you produce significant pit? No. So such edema is called non-pitting edema. This concept is clinically very, very important. Let me tell you a very classical example. Let's suppose there are two sisters who are having breast cancer. It's very unfortunate. But anyway, And unfortunately, breast cancer has gone advanced, and both of them develop swelling in the arm. Both of them develop swelling in the arm. In one sister, you press the edema fluid and pit is produced. And in other sister, edema of the arm is non-pitting. What's the difference? Both have breast cancer. In first case, probably breast cancer cells have obstructed the veins. And when draining veins are obstructed or compressed, what happens? That blood is going to the arm through the arteries, through capillaries, fluid is coming out, but because veins are blocked, so hydrostatic pressure in capillaries goes up, and she develops edema due to increased hydrostatic pressure, as cancer cells are blocking the veins or compressing the veins, cancer mass. Is that right? Or cancer infiltrated lymph node may be compressing or clamping a vein. So she will develop pitting edema. The second unfortunate sister, what happened with her, that breast cancer cells have gone to the lymph node and lymphatics, and her arm lymphatics are not draining well. So she is accumulating progressively proteins in the, she is progressively accumulating the proteins in the interstitial fluids of the arm, and osmotic pressure in interstitial fluid become high, and extra fluid is held there, and she develops what type of edema? Non-pitting edema. Am I clear? Any question up to this? So what I was talking about, edema of the renal losses of proteins, right? Edema of renal losses of protein. Yes, please, you have a question.
Develop the blockage because the cancer cell got into the lymphatic and develop hospital vehicles that say metastasize or metastasize.
Yeah. Right. He was just asking that if a female who was having breast cancer, then he developed edema of the arm non-pitting, it means that lymphatic metastases are there. Answer is yes. Swelling of arm in a patient with breast cancer is an ominous sign. She is going to very advanced stage of the disease. I will teach you someday breast cancer, right? Let's come back. So we were talking about that what is happening, heavy proteinuria, proteins level could not be maintained in spite of the compensatory effort by the liver, hypoproteinemia, generalized edema, especially starting with periorbital region, and generalized edema is all over the body. So we call it anasarca, but it is more in the dependent area. Eventually, if patient is all the day mobile, it will be more on the leg. If patient is lying in the bed, more on the back, depending upon, right? Gravity will distribute the edema as well. This is one thing. Secondly, these patients have more mechanisms of edema also. Tell me one thing, that this patient who is losing protein here and developing hypoproteinemia here and losing the fluid to the what? Tissue spaces. So blood volume in these patients will be less than normal or more than normal. Blood volume in a patient with this disease is less than normal or more than normal? Yes, this is less than normal, because all the body is edematous, water everywhere, but not in circulation, because from where the edema fluid came, out of circulation. Is that right? So the blood volume is less. When blood volume is less, do you think renal perfusion will be more or less? And if renal perfusion is less, kidneys start producing extra amount of renin. So in these patients, another mechanism which is activated is renin, angiotensin, aldosterone axis system. Primary mechanism of edema is hypoproteinemia, but secondary mechanisms will be triggered then. So what really happens in these patients, that as generalized edema become more and volume of the blood in the circulatory system become less, kidney may develop hypoperfusion. So reduced blood flow to the kidney will trigger the renin production, and you know the renin in the blood will convert angiotensin 1 into angiotensin. Wrong. Renin will convert angiotensinogen into angiotensin 1, and angiotensin 1 will be converted by angiotensin converting enzyme in the lungs into angiotensin 2. Angiotensin 2 can constrict the vessels by increase hydrostatic pressure, so bring more edema. Secondly, angiotensin 2 will act on zona glomerulosa of adrenal cortex, and adrenal cortex will release aldosterone, and aldosterone will go to the principal cells of the nephron and reabsorb extra amount of sodium and water. So sodium and water is held in the body. So kidney staunchly hold salt and water in the body. This salt and water, which is unduly held in the body, will add to the blood volume. Right? It is, in a way, kidney is trying to compensate the low blood volume. But this extra salt and water, which is returned to the circulation cannot hold within its own chambers. Why circulation cannot hold? Because it has low proteins. So this retained salt and water will again leak into tissues. Because of hypoproteinemia, kidney try to compensate by retaining salt and water, but because circulation is poor in protein, so this salt and water cannot be retained in circulation, and it also adds further to the edema. Then what happened? During all this, blood become hemodiluted or hemoconcentrated. Blood will become hemoconcentrated, of course. Out of the blood, fluid is going into tissue, so remaining blood become concentrated. So patient blood or plasma osmolality will be more or less? More. So blood will become hyperosmolar. Blood will become, in these patients, hyperosmolar. And this hyperosmolar blood, when it will pass through the hypothalamus, there are some areas in hypothalamus. Remember, hypothalamus is in central nervous system. There are some areas in hypothalamus which have osmoreceptors. They have special neurons which sense the blood osmolality. As soon as blood osmolality become high, those osmoreceptors trigger the release of ADH, antidiuretic hormone. ADH rush to the nephron, and last part of the nephron, under the influence of ADH, retains further water. And this further retained water cannot be held in circulation, again leak into edema. You are understanding what's happening? So the multiple secondary mechanisms of edema formation are also activated. So patient really develops very, very severe edema. Is that right? He develops severe edema. So what patient has developed up to now? Let's make a triangle. That patient has developed, problem number 1 was heavy protein urea. That led to what? Yes, proteinemia. And that led to what? Generalized edema. Is it difficult to understand? It's too easy, like kid's story, isn't it? You lose the heavy proteins become less here, it cannot hold the water, so water goes out. Then remaining blood gets hemoconcentrated, so ADH comes, remaining blood flow to kidney become less, renin, angiotensin, aldosterone system comes. Is it difficult? It's dangerously easy, isn't it? Now, meanwhile, our funny liver is trying to compensate. It is making more and more protein. When it is making more albumin and globulin, unfortunately, it also makes more lipoproteins. When liver pump up its protein synthesis mechanisms, it start producing, unfortunately, those proteins also in excessive amount which are concerned with the lipids. Lipoproteins are produced excessively. So lipid system is now normal or disturbed? Disturbed. So in a practical way, we can say when liver is synthesizing excessive proteins, lipoproteins are there. With the lipoproteins, lipids are there. So patient develop hyperlipidemia. This is the next thing. The hypoproteinemia triggers the liver, and liver will start producing eventually, right? And the result will be that patient will develop hyperlipidemia. Which lipids will go up? LDL will go up. Intermediate density lipoproteins will go up. very low density, VLDL will go up. Triglycerides will not be cleared, they will be going up. Do you think these are good news for the patient? No, and if this disease becomes chronic, patient will develop more cardiac problems and coronary artery events and other atherosclerosis related problems will be there. And the worst thing which will happen, all these bad lipids going up and some patient HDL will go down. So we don't call it hyperlipidemia because some lipids are going up and other are going down. Even the total lipids go up, especially plasma cholesterol goes up. Some people call it just dyslipidemias, right? But for practical purpose, you must remember that there is hyperlipidemia. Sometimes this hyperlipidemia is so severe that if you take the venous sample of the blood and put into a tube, you will find that number one, their blood is darker than other people because it is hemo concentrated. And number two, at the top of the tube, at the top of the blood, you will find a lot of yellow color material. What is that? Floating lipids. I have seen this thing myself, right? That when you are taking the sample, lipids come at the top. Is that right? So severe hyperlipidemia develops. When so severe hyperlipidemia develops, then not only proteins leak, lipid also start leaking. What starts leaking? So patient develop with all this thing one more feature, and that is, yes, lipid urea. So primary problem was just heavy protein losses. So heavy protein losses that liver could not maintain the plasma protein levels. So resulting into hyperproteinemia, leading to generalized edema, right? By primary mechanisms and activation of secondary mechanisms, which may be multiple secondary mechanisms. With that, hyperlipidemia and eventually translating into lipiduria. Meanwhile, don't forget these funny cells. They're so stupid, they eat whatever they find. So previously they were eating the proteins and now they will take a big chunks on lipids. They become full of lipids and they will become loaded with fat globules. And of course, do you think this cell will be now very healthy? No, it's like a obese man. So what happens? These cells become dysfunctional and shut down and appear into urine. So in the urine, you may find some cells with a big fat globule. We call it fat oval bodies. What do we call them? Fat oval bodies. What are these? These are the proximal convoluted tubular cells loaded with the fat shed into urine. Am I clear? No problem up to this. Whole this picture is called nephrotic syndrome. Nephrotic syndrome. All this thing which happened to the patient number 3 is nephrotic syndrome. So how do you define now nephrotic syndrome? Nephrotic syndrome is a clinico-pathological condition which develops when there is significant damage to the glomeruli, which is leading to heavy proteinuria. Heavy proteinuria cutoff point is in adult 3.5 grams per day, right? And that is associated with hypoproteinemia, generalized edema, hyperlipidemias, and even lipiduria. So we just say patient has nephrotic syndrome. Let's suppose, Abdul, you come here, please. Don't focus on his pants, right? Now, so we just suppose that this person has nephrotic syndrome. Is that right? He must have a lot of edema. He will have some more problems also. Not only this. Once I put we'll talk the other problems later. Once I put the diagnosis that this patient has nephrotic syndrome, do you think diagnosis is really complete or not? It is not complete. Why it is not complete? If I say this is a patient of nephrotic syndrome, still you don't know what damaged the kidney. Do you know? Nephrotic syndrome only tells you one thing: this is a patient who has so much damage to his glomeruli that nephrotic range proteinuria is there. Now in the discussion I will not call heavy proteinuria. This heavy proteinuria which lead to the whole this clinical pathological condition, good nephrologist will call this patient has nephrotic range proteinuria. And patient number two, he had also proteinuria, but maybe it was only 2 grams per day. And he did not develop generalized edema, he did not develop significant hypoproteinemia, he did not develop hyperlipidemias or lipidurias. So second patient cannot be called nephrotic. So difference in second and third was that second patient has proteinuria which is less than the nephrotic range. So we say what type of proteinuria is this? Subnephrotic range proteinuria. Subnephrotic range proteinuria. And what is this? Nephrotic range proteinuria. Is that right? Am I clear? Just telling you that patient has nephrotic syndrome does not complete the diagnosis. You just know that there is damage to the glomeruli, but you don't know what thing is damaging that. What is really changes, histological and immunofluorescent changes in kidney? What are the immunological changes in the body? We don't know. What triggered this damage? 10 patients with nephrotic syndrome, and each one may have a different cause of and different mechanism of damage to the glomeruli. So we say that nephrotic syndrome is just a clinical phase of glomerular injury. It is a phase, but you don't know what's behind. It's just a phase showing you that there is some glomerular damage going on. The simple, these are what I'm discussing with you. I'm discussing with you the clinical presentation and clinical phases and clinical manifestations of glomerular injury. That with the slightest glomerular injury, the clinical presentation will be, or biochemical presentation, the urine will be selective proteinuria. If there's more injury plus 2 injury, you get non-selective proteinuria. But if you don't have generalized edema or hyperproteinemia or hyperlipidemia or lipiduria, then you do not have nephrotic syndrome, and we say this proteinuria is subnephrotic range. And in this case, we say proteinuria so heavy that it has turned the whole patient pathophysiology into nephrotic picture. So this is a patient with nephrotic syndrome. Now you understand the whole nephrotic syndrome, that there is significant damage, and result is heavy proteinuria, hypoproteinemia, generalized edema, hyperlipidemia, and lipiduria. Then there is more to this thing. Actually, not only albumin leak in nephrotic, some other small molecular weight proteins also leak down. For example, one of the very small molecular weight protein is transferrin. What is that? Transferrin. And if nephrotic syndrome lasts longer, I told you different patients have a different reason of nephrotic syndrome. So some patient may develop nephrotic syndrome only for short time, and some patient may have nephrotic syndrome for years and years. If you have nephrotic syndrome for a long time, you're losing the transferrin. Transferrin is a protein which transfer iron in the blood. So iron handling in the body will be normal or abnormal? Abnormal. So patient may develop iron deficiency anemia, but only in the chronic cases of nephrotic. Then another protein which leaks down the system is antithrombin 3. This is a protein which prevents the undue thrombogenesis in the blood. It is against the thrombin system. Antithrombin 3 is a thrombin cutter. It destroys some of the activated coagulation factor. This protein is normally present in us. It's a very small molecular weight protein. So it is lost into urine. And when this protein is lost into urine for a long time, blood is losing anticoagulant proteins, so blood will become procoagulant. So patient will develop thrombosis more readily. Am I clear? Right? So many of the patients with nephrotic syndrome develop thrombosis in the veins, especially renal vein thrombosis. So these patients have thrombotic tendency. One of the reasons for thrombotic tendency, only one reason is, there are multiple reasons of thrombogenesis, but one reason in these patients of thrombogenesis is loss of anticoagulant proteins into urine. And then there are more reasons. What are the reasons that these patients undergo repeated thrombus formation. Number one is loss of antithrombin 3 or other anticoagulant proteins. Number two may be due to hyperlipidemia. Lipid incorporate and disturb the platelet membrane. And you know, when platelet membranes are disturbed, they love to stick to each other. So thrombogenesis. Then high lipids also disturb the membrane of endothelium. When endothelial membranes are disturbed, that also becomes thrombogenic. And then of course, highly concentrated blood, hemoconcentration. Blood flow is fast or slow through the veins. Stasis, further adding to thrombogenesis. So there are multiple reasons why these patients develop a tendency for thrombogenesis. And story does not end up there. Some more very important proteins also leak down. What are those? Maybe some of the immunoglobulins. But more importantly, low molecular weight complements are lost into urine. And if low molecular weight complement proteins are lost into urine, do you think if patient has less complement factors in the blood, patient can fight with the infection effectively? No, because antibodies with complement are the real fighting machine against many bacteria. So these patients have low chances of infection or high chances of infection? High chances of infection. Many of them die due to infections. Right? Maybe nephrotic syndrome does not kill, but complications of nephrotic syndrome kill. For example, when complements are lost into urine, patient's immune system is disturbed and weak. These patients especially develop pneumococcal infection because we need complements to kill the pneumococci because they're capsulated, and we need C3b as opson N if you have studied the complement system. You know, there's something called C3b that help the bacteria to stick with the neutrophil and macrophage and facilitate the phagocytosis of bacteria. Those things are lost. Right? So patient has increased thrombotic tendency, patient has increased tendency for infections. Is that right? And another thing, usually these patients have frothy urine. Why their urine is frothy? High protein level. Proteins in the urine make the urine frothy. Is that right?